Now we can start.
Thank you, Marci. Very good evening to all participants and speakers to this Asami India Masterclass. Asami India has taken this initiative to have a monthly masterclass on various topics related to limb reconstruction. And in that series, the Gujrat state is going to have their webinar sorts in today on bone transport. We have eminent speakers like Professor DENIS MOKOVIKOV. Sorry if I've pronounced it correct, incorrect. Dr. SONI, who is named by himself and famous for transports. So is PURAV KANSARA and Dr. Harjeet. They are the speakers for the day. And now I hand over to Shamsul for the introduction of the faculty and the further proceedings.
Thank you, sir. And very good evening to all. So I welcome you all for our another very important masterclass series of Asami India. And today we have a very interesting topic of bone transport, where we have eminent national and international faculties. First, we have Professor DENIS MOKOVIKOV from KURGAN, Russia. Then we have AMAR Sonia JAYANT State, and we have SINGH and KANSARA. Now let me introduce our international faculty. So Professor DENIS MOKOVIKOV or MOKOVIKOV, DENIS Sanjeev is the head of Traumatology and Orthopaedic Department, number 4 of the Ilizarov Center, candidate of Medical Sciences, researcher at the Laboratory of Clinic for Reconstructive Osteoarticular Surgery of Children and Adults, traumatologist, orthopedist of the highest category, member of Asami Society Russia, member of Association of Traumatologists and Orthopedists of Russia, like orthopedic pathology of adults that includes consequences of injuries and surgical interventions, improperly healed fractures, long bones, defects, deformations, shortening, and false joints, including the presence of foreign bodies like rods, screws, bone plates, knitting needles, etc. Benign tumor and tumor-like bone diseases and consequences of injuries to large joints, degenerative disease of hip joint, and then in the pediatric orthopedic pathology, his work on consequences of injuries and operations, deformations and shortening of limb segments, congenital pseudoarthrosis like false joints of limb segments, benign tumor and tumor-like bone diseases. He says practice methods of treatment following the transosseous osteosynthesis according to G. Ilizarov. Locked intermittently osteosynthesis, various options of bone grafting, combination of methods like synchronous, sequential, submersible, and transosseous osteosynthesis. Let's work on hip replacement. The main direction of scientific and practical activities is like optimization of the treatment process in patients with orthopedic and traumatological pathology, complicated and uncomplicated purulent infection, development of new pathogenetically subsequent expedient methods of surgical treatment aimed at comprehensive restoration of anatomical and functional state of the limb, general hemostasis and persistent suppression of purulent inflammatory phenomena, and combination of submersible and transosseous osteosynthesis in methods in the treatment of patients with consequences of trauma to limb segment. These are his contacts. His email is like T004 at rnctu. So now I request Professor DENIS to share his talk. DENIS, over to you, sir.
Okay, I'm glad to see you, my dear friends, my dear colleagues. Are you here and see me okay?
Yes, sir. Yes, sir.
Yeah. Can I start my presentation for you?
Please do, sir.
Okay. It's okay?
Yes, sir. Please go full screen, sir. Yeah. Not yet. Please go full screen. Yes, sir. Please go full screen, sir. Please go to slideshow mode. Slideshow mode or full screen.
Full screen. I try to do it. I make a full screen.
No, the first slide, sir. On the bottom right, on the bottom right, sir, you have a button of full screen just beside 76%. All right. More right to it, sir. More right. The button just right to it, sir. Just yes, sir. Yes, exactly. This one.
Okay.
It's not going full screen. Okay, sir. We can start from the first slide, sir. No issues.
Do you see the slide?
Yes, we can see, sir.
How can I make a full screen? I see the full screen in my presentation.
But Maharshi, can you help?
Yes, sir.
Can you help Professor Dennis go full screen? He's not able to do.
So just click on this page, double tap.
Yeah,
Hello.
because
You should try to double tap on page.
Go in the slideshow mode, sir.
Double tap.
What can I else do? I see the full screen of my presentation.
Okay, you are seeing the full screen. Any settings in the computer that you can help Maharshi? Jan sir, shall we start with this also? Jan sir?
Sir, I cannot understand that language.
Language. The language is a problem, sir. Wait a second, sir. In the options, you have a slideshow mode and go the top.
Sir, in download there are option plus or minus. Right
Yes,
side,
right side, you
bottom.
can at least zoom out.
Or I think that the option on full screen also in bottom right side. Right side.
So on the top, you have a first, second, third, fourth, fifth, sixth option is slideshow on the top, sir. I can see through Google Translate.
Nice idea, sir.
Yeah. Just beside 76%, click on the full screen. Jan sir, shall we start like this? Is it okay?
It's okay?
I think we can start, sir. It's okay. We can do like this.
Yeah,
Sir.
we
It's
can
fine.
start with
Okay.
this.
We can start.
Okay,
Sir.
may I start?
Yeah, please, sir. Please, sir.
Okay. Dear
Maharshi,
colleagues,
please,
I want to represent you some cases of the treatment of patient with pseudoarthrosis and defects of bones with bone transplant from Ilizarov. The clinical base is our department number 4 of the National Medical Ilizarov Center, and we have some experience of the 14 years of our department.
So the slides are not moving, sir.
Also, we have Ilizarov transosseous osteosynthesis, interlocking intermediary osteosynthesis, various variants of the bone plastic and combinations of these techniques. But today we will talk about the native Ilizarov transosseous osteosynthesis. You see that the relevance is so much for it.
Sir, we can see just the first slide, not the next slide, sir. Please click on the next slide.
cannot see anything.
You can just see the first slide, sir. On the side, you can go to the next slide.
Now you see my presentation.
No.
You can just see the first slide. I cannot see the next slide, sir.
Do you see anything?
Yes, sir. We can see your first slide.
And now
it's not moving. Sir, I've sent you my email. You can share your presentation to my mail. I'll run for you. In the chat box, I've shared my email.
Shamsul.
Sir.
What can I do for you?
I've just shared in the chat box my email. You can just mail your slide to me. In a moment, I'll answer. Have you seen my message?
Next ওরা ওই একই অবস্থা রুম পড়াচ্ছে
Ashok, please mute everybody else.
Okay, sir.
Sir, have you mailed to me, sir? चलेगा चलेगा साथ. In the meantime, as Jan sir is saying, we can have Dr. Amar Soni's talk first, and then in the meantime, I'll get the email of Professor Denis. Jan sir, please. Professor Denis, please unshare. In the meantime, as Jan sir is saying, we can have Dr. Amar Soni's email of Professor Denis. Jan sir, please. Professor Denis, please unshare.
Maharishi, Maharishi, there is echoing of the sound coming. Like
Okay,
what
sir.
Shamsul spoke was repeated again after some
Yeah, I
seconds.
think there was YouTube going on. Now it's okay, sir. Is it okay now, sir? I think it's okay now.
Okay. So now,
Dr.
Amar,
Amar,
you start with
Yes,
that.
yes.
And meanwhile, Professor Denis will do the corrections, whatever he can, or he'll send the mail to Shamsul. So Shamsul will run it.
Professor Denis, please mail your PPT to my email, sir. Okay.
So, my Dr. Shamsul, sir, my screen is visible now.
Yes, please.
Yes.
Oh, yes,
So,
sir.
good evening, everyone. So, what I'm talking is today is bone transport and its variants. So, earliest, if we go by history, earliest reference in Western literature about attempted dissection are from Cordula as early as 1904, and his disciple Potti in 1921 he presented in a Journal of American Medical Association about elongation of bone through osteotomy. In first half of 20th century, there are many publications about dissection for lengthening, but there is no way to assume that Ilizarov had access to such publications. So even in later part of 20th century, Wagner had attempted lengthening with external fixator and diaphyseal osteotomy, but morbidity was too high with multiple complications. And basically all attempts were to create a gap to be filled with bone graft. To my knowledge, none of them have documented the process of dissection osteogenesis. This is a beautiful caricature by Professor Dr. Vladimir Golyarsky, and it says that the way Newton had discovered a law of gravity, similarly Ilizarov had discovered the law of tension stress forces with just an anecdotal incidence of amputation stump learning in a World War II veteran. So what history has noticed that science, in whatever progress science has witnessed, there are two types of genius. One is genius discoverer, who brings out new idea, and genius of completion, who develops an existing idea. Ilizarov belongs to one of rare category of genius who not only develop an idea, but bring that to its logical conclusion. So what others could not do, Ilizarov did. He brought that anecdotal incident of amputation stump landing to its logical conclusion. He did extensive animal and clinical research on biological principles and stability concept and histological mechanism. He defined optimal rate and rhythm, and he emphasized the need for preservation of blood supply while doing corticotomy. And due credit must be given to Ilizarov for this. So, out of this dissection osteogenesis with Ilizarov apparatus has many applications. Out of that, I will be talking on bone transport and general overview of bone transport. I will not limit my discussion to case-based discussion, but I'll give you a general overview of bone transport. There are various methods of bone transport. One can classify it in monofocal, bifocal, trifocal, and tetrafocal. There are some variant plus fibular transport and some hybrid methods. In detail, each method. Monofocal osteosynthesis. What Ilizarov has observed that dissecting hypertrophic non-union converts fibrocartilage into bone, and this corrects not only deformity but gains length to a certain extent. If you lengthen more than 2 centimeters, the regenerate quality is not that good. In bifocal osteosynthesis, process of bone healing occurs at 2 sites: osteogenesis at dissection site and healing at non-union site. Gap is more than 4 centimeters. What we do is dissecting this corticotomy at 1 millimeter per day and compressing the gap at 1 millimeter per day. Eventually, this will traverse and will reach to this part, and this part will have a regenerate, and this fragment will dock to other fragment. This is a case example will open grade 3B fracture treated with primary Ilizarov. One can see here that all rings are connected with individual rods, and there is a proximal block, distal block, and a floating segment, and proximal tibial corticotomy done. Here length remains same, and the gap was 7 centimeter. The individual rod, when we connect each ring with individual rod, essentially what happens that there is lengthening at corticotomy site and shortening at gap site. So these addresses soft tissue defects simultaneously. While using single rod, there is a pure internal bone transport. And this is his outcome at 10 months. Regarding fibula osteotomy, it is optional while index surgery is done, but I usually do fibula osteotomy in simultaneous dissection and compression at the time of docking. And in some cases where there is not only defect but gap but shortening also, in those cases post defect is addressed at the time of docking, one need to continue the dissection in order to address the limb-length discrepancy. In some cases where the gap is less than 4 centimeters, especially in tibia, one can opt for acute or accelerated compression at gap site. And in those incidences, one can gradually dissect corticotomy site to gain the length. In this condition, in leg, one need to do fibular osteotomy in order to compress acutely. And patient will have some pseudoparalysis-like effect due to decrease in lower arm of muscle, which eventually that strength will gain as length is gained. This is an example where a small gap was compressed acutely and gradually dissected at distal corticotomy. This has some inherent advantages, especially in femur. This patient reaches the stage of docking and union process begins early. Second admission and surgery for docking is avoided. Axial deviation of transported fragment is avoided. And follow-up visits are not as stringent as those in bifocal simultaneous dissection and compression. And in some cases where patient is non-compliant, patient will end up with some residual shortening, but union prospect will not alter. All those patients in which we do acute compression or accelerated compression will require compensation in footwear in early stages in order to ambulate them. In those cases where the gap is very large, one can use such dummy ring to allow patient to walk earlier. Regarding trifocal osteosynthesis, I'll go through why the trifocal osteosynthesis is required. On an average, healing index is around 30 to 45 days per centimeter. That means if a patient is having 10 centimeter gap, expected duration in frame would be 10 to 15 months. And whenever frame is kept for such extended period, say more than 15 months, wires deform plastically, there are pin tract issue, frequent follow-up visit, loss of wages, and at times cumulative effect of this leads to premature frame removal, refracture, persistent non-union, and in some cases even amputation also. So what options we are having? Can we fasten the dissection, means reduce the dissection phase, or can you reduce the consolidation phase? Regarding reducing the dissection phase, one need to dissect more than 1 millimeter per day, and that will lead to frustrate the neocapillaries and lead to hypertrophic regenerate. So this is not a good idea to dissect for more than 1 millimeter per day in order to reduce the dissection phase. To reduce consolidation phase, what Professor Kettani has suggested is consolidation time of regenerated bone segment is inversely proportional to its length. So two shorter fragments will consolidate more rapidly than one long segment. So a 10 centimeter gap will heal more rapidly if 5 centimeter dissection gap is made in the same segment. So there are two variants, converging trifocal and tandem trifocal. Whenever there is a large diaphyseal gap more than 8 centimeter, one can opt for converging trifocal osteosynthesis, where a proximal and distal corticotomy and transported fragment will converge towards each other to reach the docking. This is a case example where grade 3B fracture presented at 1.5 months with exposed avascular bone. This preoperative planning, dotted white line is suggestive of tentative area of resection. White lines are tentative placement of ring, and red lines, dotted red lines are tentative place where corticotomy will be done. This is a prefabricated frame and post-op image. This proximal and distal corticotomy done once soft tissue stabilized. And such patient in converging trifocal will have a very near second and third ring, and one need to replace those ring in order to have a good radiological visualization for follow-up period. This image at 10 months where good regenerate consolidation and docking side union is seen. When the gap is eccentric, say more than 8 centimeter gap, but it is eccentric situation, one can do two corticotomy in a long fragment. One would be metaphyseal, other would be diaphyseal, and in such situation, transported fragment will run in tandem to reach towards other end. That transport would be from proximal to distal or distal to proximal, depending on the location of the gap. This is an example where a large avascular fragment is there, then that was removed. Dotted lines are tentative area of resection, and red lines are tentative area of corticotomy. This is how a prefabricated frame would look, and this is immediate post-op image. Regarding use of all wires versus half pin, in transported fragment, if you use two wires, then they will have a minimal spanning, say less than 30 degree. In contrast, if you use a one middle face wire and half pin, that will have around 90 degree spanning, that will prevent toggle and give good stability. And I prefer to use individual rods instead of single rod. As it is very difficult to comprehend trifocal transport with single rod connecting from first to last ring. This is an example where segmental open tibia fracture presented to me. Initially, I thought of preserving middle segment, but when I opened it, it was totally avascular. So around 20 centimeter bone was removed and bone ends were refashioned. This clinical picture, proximal metaphyseal corticotomy, and below it a diaphyseal corticotomy done images while transport, and eventually at 11.5 months it united nicely without limb-led discrepancy and with good functional outcome. All patients with trifocal osteosynthesis with large gap will have inherent risk of developing equinus. So one should apply a footing in order to prevent equinus. And in some cases where there is a pre-existing equinus, one can use footing to correct that equinus. And that footing is usually removed 6 post-docking. Regarding docking, if there is an intact soft tissue sleeve, one can opt for closed docking. When there is a large soft tissue defect, skin invagination will surely occur, and those patients will require open docking instead of closed docking. Regarding tetrafocal, this is quite an uncommon situation where there is a segmental fracture with segmental defect where two corticotomy is done and process of healing is occurring at 4 different sites. So the term is tetrafocal. I'll just go through one example where a segmental fracture where both proximal and distal part where bone were exposed with knee FFT and ankle equinus. Patient was treated with frame and diaphyseal and distal metaphyseal corticotomy done, reached the stage of docking at 8 weeks, and eventually it healed at 10 months with good functional outcome. Regarding cross olive wire, these are bone transport variant. I'll go through each in some detail. When a size of fragment is too small, to allow additional ring, this cross olive wire method is very useful. And to use this method, one need to have good soft tissue sleeve. It is contraindicated when there is a poor soft tissue sleeve, and it is not recommended in patient where gap is less than 5 centimeter. This cross olive wires pulls the transporter fragments of horse, and they are attached to distal ring with threaded rods, slotted threaded rods, or female hinge. And there is an empty ring empty second ring. Eventually, at the time of docking, transverse wire are inserted, and these cross olive wires are removed. So this cross olive wire avoids transecting scar tissue as it happens with transverse wire. This is the main advantage of using cross olive wire technique. But these wires are not tension one, and if one is using hybrid frame, one need not have that difficulty, and I avoid using this cross olive wire method. I rarely use it. So about cable transport. To be truthful, I do not have any personal experience with this method. Dr. Singh sir will cover this topic in later part of this session. Everyone who is familiar with bone transport must have noticed this such scarring which happens with simple transverse wire conventional transport, and it is because skin is cut through every time we distract at corticotomy site. So this cable transport is done at pretext of increasing the patient's comfort, and it prevents soft tissue related to skin excursion, and soft tissue invagination and malalignment is prevented. Smith & Nephew is having this elaborate system of cable transport, and if one is not having, one can simply use a CC screw and use a simple SS wire to do so with LRS. So intake soft tissue sleeve is must, and transport in flap. This is very useful technique in patient with transport in a flap cover area where excursion of half pin and KVAS may compromise flap survival. This technique is not useful when we wish to correct simultaneously deformity and gap, and when there is a rotational deformity element present. Regarding unicortical bone transport, this 65-year-old male had persistent discharge since 5 years, and he was on and off antibiotics since 5 years. This is how post-debridement cavity looked, and skin incision kept depending on size of cavity, and 2 drill holes are made for half pin insertion. Multiple drill holes are made, and those are connected with 5 mm osteotome to create a unicortical bone, which is transported with the help of 2 half pin. This post-op image shows multiple drill holes which are connected with osteotome, and corticotomy is completed. One can see here that there is a big cavity of 6 centimeter by 2 centimeter, and pie crusting attempted for skin closure, but it was not successful. Eventually, these are images during transport. Initially, I did transport at lower rate, and then gradually at 4 times a day. And at 4 months, the frame was removed, and the transported fragment was fixed with 2 interfrag screws. So the suffering of 5 years was ended in 4 months duration, and both bone and soft tissue defect healed simultaneously without flap, without bone graft. And the best part is patient remained ambulatory during whole course of treatment. Regarding transverse bone transport, this Burgess disease is an inflammatory disorder of small and medium-sized artery of unknown etiology, with strong association with smoking, and conservative treatment with drugs like vasodilator, prostaglandins, and sympathectomy has limited roles in modifying the course of disease. One must stop the smoking in order to have an optimal outcome. And we all know, and it is even angiographically proven fact, that dissection osteogenesis lead to 330% in increase in vascularity. And this improvement in blood flow has several implications. It relieves rest pain, improves claudication distance, it heals the ulcer, it limits the level of amputation, and allows resumption of activity of daily living. There are various ways in which we can transport. This one way is to use an olive in which a lateral cortex needs to be over-drilled. Another way is to use half pin. Instead of half pin, one can use cross K wires also. Regarding fibular transfer, one can have a vascular fibula, non-vascular fibula, tibialization of fibula, or graduate transport of fibula. We'll go through each in some detail. This vascular fibula is an excellent option when facilities are available in treating very large defects, say more than 15 centimeter. It is very good in tibia. I less often recommend it in femur. when there is not enough healthy bone for 2 or 1 corticotomy, and the soft tissue void is not as, say, post-irradiation in peripheral vascular disease. The only limitation is it requires patient to be shifted to tertiary care center where expertise of vascular and plastic surgeon to do required microsurgical anastomosis is there. And it has some donor side morbidity issues, and in some cases the infection and fracture of this vascular fibula also seen. This is another option is non-vascular fibula. I do not recommend it, and one should not attempt this because it takes very long time to union, very long time hypertrophy. Needs to protect this in cast and breast because chances of refracture are very high, and unprotected weight bearing takes very long. So if you go through cumulative morbidity of this procedure, it is very high. Regarding tibialization of fibula, this procedure was described by Thomas Huntington in 1905, and tedious era it is rarely being used. I have seen some surgeon in Middle East using this technique. I have not used this technique because I prefer bone transport over this. Is gradual transfer of fibula. We have witnessed an excellent talk by Dr. R.A. Agrawal sir during last Asami on this topic. This case is operated by Dr. P.N. Vasudevan sir, and he has kindly consented and given it to me to present in this. This 57-year-old gentleman presented to him 2 years post injury with 15 surgery, including vascular fibula, which eventually got infected, and he was awaiting amputation. So if this patient would have gone with conventional bifocal or trifocal osteosynthesis, it would have added more morbidity in already patient who has been operated in so many times. So what sir chose was a segmental fibula osteotomy, slow transfer of fibula towards tibia. The fragment was docked at 3 weeks and frame was kept for 4 months, and he was protected in PTB breast for a period of 1 year. If you see eventual outcome, fibula is nicely united both proximally and distally with tibiofibular synostosis at both levels, without limb-length discrepancy, without bone graft, without clap cover. So this limb is salvaged with minimal morbidity. This is a case example from Sir Elizarov's book of transosseous osteosynthesis. This patient was treated 50 years back, and Herculean tasks achieved with least morbidity. Segmental osteotomy of fibula, gradual transfer, and if you see the eventual outcome, see the fibular hypertrophy. Fibular hypertrophy is such a beautiful way that it allows full weight bearing unaided ambulation over a period of time. Hybrid strategy. One can have a transport over nail or plate, or transport followed by nail and plate. We'll go through both in some detail. This transport over tens or endus. This procedure is done for following purposes: to achieve and maintain reduction, to prevent axial deviation of transported fragment, and to facilitate early frame removal. I do not use tens to do so because I feel that adequately stable frame is sufficient to serve above mentioned purpose. But one can surely use it, and it is a good option. Transport over nail or plate. One need to carefully select the patient. Aseptic gap nonunion are the cases where one can do so. Strategic placements of wires and pins, and still there's an inherent risk of pin track issue, and if that happens, that will ruin. So I'll just give an example. There are 4 different cases presented in this slide. Out of this, only first one is amenable to transport over plate. Second one is infected nail. Third one is infected nail in femur. And fourth one is pathological fracture. So second, third, and fourth are not amenable for transport over nail. I'll give an example where I had treated a case with transport over nail. This patient had a comminuted femur with gap, and he had ipsilateral compartment syndrome in leg and equinus in ankle equinus. So that patient basically came for treatment of this foot deformity, and I offered him simultaneous correction of addressing the non-union also. I applied a 3-ring frame with 3 fixation point in proximal ring, 3 in distal ring, and 2 in middle ring, where 1 wire and half pin was there. And corticotomy was done between second and third ring, and frame was kept for 2.5 months in femur and 4 months for ankle, and eventually it healed without bone graft. One is having infected non-union with nail in situ, and one wishes to do a transport over nail. It has a lot of inherent risk and morbidity. This patient was treated elsewhere where nail was removed and antibiotic coated nail was given. 6 weeks IV antibiotics were given, and at 6 weeks that nail was again removed and renailing and transport cable transport was done and frame was applied, which was kept for 6 months. So overall duration of treatment was 7.5 months. Conventional, say, trifocal osteosynthesis would have taken, say, a few more months, but would have a lesser morbidity. Regarding transport over locking plate, this is not an anecdotal or experimental procedure. Even AO MIPO book has mentioned it with this illustration and some case example. The only thing which I differ with this is the configuration which they have shown is not sturdy enough to prevent varus failure and to allow full weight bearing. This is a case example which was treated elsewhere at tertiary care center, where transport over plate was attempted. Patient was kneel bedding for 10 months, partial weight bearing for 10 months. Patient had 10 admission and prolonged IV antibiotic. So things are not as simple as it seems. And there is transport over LCP with LRS do not allow patient to walk full weight bearing in initial period, and there are still inherent chances of varus failure or fatigue failure of implant. This is one of case which I have treated with transport over frame. Transport over plate. This patient had aseptic gap non-union. I did implant removal, put a long plate, and this way I have applied a frame. One can see here that there are 3 fixation points in proximal fragment, posterolateral and posteromedial, and transverse wire in distal fragment, and 2 5 mm half pin in middle ring, and percutaneous corticotomy through anterolateral incision. Generally, we use lateral incision to do corticotomy. Here I have used an anterolateral incision to do corticotomy. And at 2.5 months, docking was done and frame was kept for another 1 month. At the time of docking, half pin were removed and 2 locking screws inserted in transported fragment, and bone graft was kept at docking site. So another strategy would be transport followed by a plate or nail. This is a case example of patient who belongs to community who are wandering, who do not have any permanent resident, and who belong to very low socioeconomic class. He had floating knee, open distal femur fracture with bone loss and segmental tibia fracture. I had applied frame in that. He had 6 centimeter bone loss. At 6 weeks, he presented again with fracture neck femur, which I had treated with CC screw. And eventually, 2.5 months docking was done and frame was removed at 4 months. At 1 year follow-up, his neck femur and regenerate consolidation and distal femur fracture and tibia fracture all had healed with reasonable range of knee motion. In some instances, post-transporting tibia, there is persistent non-union at docking site. One can opt for interlock nail, which heals the non-union site. And this is a case example where I have used this strategy. Regarding internal transport with precise nail and plate-assisted internal transport, to be truthful, this is beyond scope of my talk, and there are some issues with this. Whenever a patient is having infected non-union, one need to convert it to non-infected non-union in order to use this nail. In grade 3B fracture, one need to have a soft tissue coverage first before doing internal transport. In real life scenario, we hardly get some cases where there is a pure aseptic gap non-union, and cost is prohibitively high for our Indian patient to use this device. We all know that this auto-destructor leads to good regenerate consolidation because 17 micron dissection is done in 60 steps at every 24 minutes. And this dissection rate mimics the growth happening in embryonic life. With such a small fraction, one can even dissect up to 1.5 to 2 millimeter per day without adversely affecting neocapillarization. So till date, auto-dissector are used in context of limb lengthening only. But someday one can use it in context of segment transport, where we can reduce dissection phase around 1.5 to 2 times, and eventually consolidation phase also reduce, because this leads to good regenerate consolidation. So bone transport itself has some inherent issues also, like extended duration in frame. That part which I have addressed to some extent in this my talk. The other elements regarding regenerate issue, stability, and docking site issue, one need to take care and address in order to give optimal outcome to the patient. So my take-home message would be learn the art of bone transport, master it over a period of time. It will help in salvaging many seemingly non-salvageable limbs. Focus on adequate stability and good rehab and address docking site issues. Every trauma surgeon needs to know basic of Ilizarov. Similarly, every Ilizarov surgeon should know some basics of trauma too. At times, hybrid fixation builds out from persistent non-union post-bone transport. Thank you. Thank you all.
Yeah, Shamsul, any questions from the audience?
Not in the internet, sir. Sorry, Dr. Soni, I couldn't give you introduction because of the switch of the talks.
No, sir. No problem, sir. It's
Amar
okay,
does
sir.
not need any introduction. He
No,
is
sir.
a well-known
Exactly.
figure.
Exactly.
No need, sir.
So, sir, do you have any questions from the
He is
panel?
one of the
Yeah.
Hmm.
Yes, sir. He's our international faculty.
Hmm.
yeah, and one of the office bearers of the Asami. So is his program.
Hmm.
Yes,
Thank you,
yes,
sir.
yes.
Thank you, sir.
So, do we have any question? Baris sir, Dr. Bera, Dr. Rizwan, Professor Omer? Everybody is switch off the video. Marshi, can you allow everybody to unmute?
Okay, sir.
Please allow to unmute everybody. Allow to unmute.
Done, sir.
Yeah.
Yes,
sir.
can you hear me now?
Yes, sir. Sir, we cannot see you, sir.
Thank you. I have no question. Thank you so much.
Oh, you are not seeing me, eh? Okay,
Yeah.
you can hear my voice, eh?
Yes,
Yes,
sir.
sir.
Oh, it's very good. Thank you very much, Amar Sani.
Thank
My
you,
one
sir.
question,
Yes, sir.
regarding the transverse bone transport.
Yes, sir.
Okay, you have shown the Burgess disease because it's very good technique.
Yes.
I'm using lots of cases this for
Yes, sir.
Burgess and at the same time for diabetic foot patient.
Yes, I
Diabetic
have gone
foot
through your article also, sir.
Yes. And
Yes,
after how many days you go for distraction when you are doing TTT,
sir,
tibial transverse technique?
sir, around 10 days. And
10
initially,
days.
the distraction would be at slow rate, say 0.25 mm twice a day only.
Thank you. This is good.
Yes,
This is the information
Mm.
for the young orthopedic surgeons because in the metaphyseal region we are going for 4, 5, 6 days, but for here 10 days because the cortical bone. That's why
Yes,
you should have to wait for a long time.
yes,
And
sir.
outcome is very good. It's a fantastic
Yes.
result.
Gratifying to patient, and he remembers the
Yes.
amount of rest pain and cloud relieved is so magnificent, means so good, and the claudication distance increases like anything. Means
Yes.
they feel so happy.
Yes. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Hello. Soni, just
Yes,
I
sir.
have one question.
Yes, sir.
Is a trivial transverse transport.
Yes, sir.
So after widening, their tibia becomes thick. The
Yes.
Chinese, they are doing again repositioning it back. What's
Not,
your
no,
do you
no,
got the
sir, we dissect hardly for 5 to 10 mm, and that much widening patient accepts without any difficulty. The amount of pain relieved is so that you will not have any issue with such cosmetic issue, and that's not
Okay.
painful.
Okay.
Yes, sir. Thank you, sir.
Okay.
Any more questions, sir? Omer, sir, Denis, sir, any questions?
Excellent talk. Okay. No explanation. I will see.
Thank you, sir.
Haji, sir, any question? If you have any question, then we can move to the next talk by Denis, sir. Jen, sir.
I'm okay. Do you hear, see me?
Yeah. So shall I start Professor Denis' presentation?
Yeah, we should start without
So,
wasting much time.
yeah, Denis, sir, I'm just sharing your talk. You just have to say next to move to the next slide. Okay, sir.
Okay. Okay.
Can everybody see the full screen?
Yeah.
Yes.
Yes.
Okay.
Yeah, then sir, please start.
May I
Sir.
start my presentation?
Yeah, please, sir.
Okay, I want to take you about treatment of the patients with pseudoarthrosis and defects of all bones, and often with bone transport. Next slide, please. No, we have a clinical base. Our department, the fourth department of the National Medical Reserve Center of Traumatology and Orthopaedics, and over the 14 years, we have a big insurance. We have a big implants of the treatment of such of these patients. Okay, next slide. Next, please. We often have a treatment techniques with Ilizarov transosseous osteosynthesis, interlocking intermediate osteosynthesis, various variants of the bone plastic, and combinations of the techniques. Next slide, please. You see that the prevalence is all the problem of in our country and in main of the world often. Next. Now we can define what means the bone defects. So in our classifications of the Shevtsov and Makushin, we have the defect pseudoarthrosis and defect diastasis of the long bones, and the definitions in the 1 centimeter of diastasis. Over the 1 centimeter, we have a defect pseudoarthrosis, and more than 1 centimeter between the bones parts, we have a defect diastasis. Next. The defect pseudoarthrosis we classified by the hypertrophic, normotrophic, and hypertrophic. You know it. The next. You see that the types of pseudoarthrosis by the classifications with the Weber and Czech. We have touchable and removal it. The viable pseudoarthrosis and the non-viable pseudoarthrosis. I think in the same classification. Next. We have a monofocal, bifocal, polyfocal osteosynthesis, compression, distractional, and compression with distractional osteosynthesis, such as the native techniques of the Ilizarov. Next. Now we see the clinical case of the young man who have a hypertrophic defect pseudoarthrosis of the tibia. Now we make the transosseous osteosynthesis monofocal with the Ilizarov frame, make the corrugal osteotomy of the fibula, the gradual compression and distraction with the roots, and now we have the consolidation of the bone. It's the classical cases of monofocal transosseous osteosynthesis, which is suffered loved by the academic. The next. Now we see the clinical case of bifocal transosseous osteosynthesis. We have a young woman with a defect of the distal part of the femur in the monoloteral fixator. Okay. Now we can we make the transosseal osteosynthesis of the femur and the tibia, proximal osteotomy of the femur, gradually bone transport with the synostosis of the fibula and the tibia, and we have a consolidation. Next, please. You see the result, and after it we make the lancering of the leg by the lancering with the tibia. Next, please. Now we have a case of the polyfocal transosseous osteosynthesis. The young woman with a close fracture of both the bones of the leg. We have the osteotomy of the proximal part of the tibia and the distal part of the tibia, and the polyfocal transosseous osteosynthesis in the Ilizarov frame. Next, please. You can see the composed of the frame. It's not so exactly, and we have a consolidation with the tibia without of the shortening of the leg after it. Thank you. Next. Now we see in post-traumatic pseudarthrosis a femoral deformity with a gunshot sequela. We have next please osteotomy from the pseudarthrosis. Next slide. Gradual correction of the 28 days, and after it we have consolidation. Next, please. You see it, we remove the Ilizarov flame and we have a consolidation of the leg. And after it, we make a lancering of the light low extremity with the osteotomy of the distal part of the femur with the Ilizarov flame by the native methods of Ilizarov. Next. Now I will show you limb defects with arthrosis with the deformities in conditions of unstable and infective fixation with internal metal catches. Next. Now we see the normotrophic pseudarthrosis with the femur with non-infective fixation. Next, please. With such old difficulties, we have removed this fixator, and often we have a lot of tragedy with the removal of the distal part of the nail. After it, we make a osteotomy from the defect pseudarthrosis of the femur and monofocal compressive osteosynthesis with the Ilizarov frame. Next, please. Now you see the consolidations, the frame was removed. Next. Now you see the post-traumatic pseudarthrosis of the humerus was in metal osteosynthesis with immigrations with the fixator. Next. We make an osteotomy and monofocal compressive Ilizarov frame. Next, please. We have a consolidations. You see the X-rays between the removal of the frame. Next. Now we'll see the fracture of the nail with the normotrophic pseudarthrosis of the tibia, and after it we remove the proximal part of the nail and make the osteotomy from them. Defect pseudarthrosis of the tibial and monofocal compressive osteosynthesis with the Ilizarov flame. Next, please, slide. You see the compression on the docking side, and after it we have a consolidation. Next, please. Now we'll see the young patient with the deformity of the low limb and the non-effective fixator. I must say that she was operated about on 10 times and no effective treatment she didn't have. Next slide. We remove the plate of the tibia, and often we see that the defect, not pseudarthrosis, we have a defect of the tibia. We make an economic resection of the tibia. After it, we make a proximal osteotomy. You see the distraction is generated right here. And after it, we have a bone transport for the docking site. Next, please. Now we see the result after 1 year and 8 months of the follow-up. After it, we planned the osteotomy of the proximal side of the tibia and distal side of the fibula for lengthening the leg. Next, please. Now we see the defective arthrosis with a non-effective metal fixator. Next, please. We have removed it, and after it we make an osteotomy of the femur and monofocal compression osteosynthesis with a Ilizarov frame on the docking side. Next, please. And after we have consolidation, the frame was removed. Next. Now I can represent you a technique of inducting biological membranes in filling in the defects of the long bones of the adult patients. Next. All of us will know the muscular technique, but we, with my colleagues, want to represent it you muscular technique in the treatment of the post-traumatic defects of the bones. Next. You see the young man who got he got the trauma in a traffic incident, and patients on perfect treatment between us with the only osteomyelitis. Now, next slide, please. We make the resection of the tibia with the implantations of the cement spacer in the bone defect, monofocal Ilizarov frame osteotomy, the proximal part of the tibia, and gradually correction with the bone transport. Next, please. Now it is a consolidation with the shortening of the 8 centimeters, but no inflammation. But after it will make a lancering of the leg with a native monofocal distraction Ilizarov frame. The next. Now I present you conventional pseudoarthrosis of the tibia. Next. Next, please, is a relevance. It's our native classification. We like it. With the Crawford was the first, second, the third, and the six types of pseudoarthrosis. Next. One more clinical case: the young woman with the conventional pseudoarthrosis of the tibial bones near fibromatosis of the first type, Crawford's the first type. She often take a treatment in his country, but with such X-ray and clinical case we have in our clinic. Next. We'll make a resection of the tibia in a distal part and implantation of the cement bones spacer and proximal osteotomy of the tibia with a Ilizarov frame. After 4 weeks, we remove the spacer and make the bone transport. Next. We have a consolidation after it, but we have a shortening of the leg. After it, we make a Ilizarov frame with the proximal osteotomy of the tibia and the fibula, and gradual correction and lengthening of the leg. After it, next slide. Now we see the lengthening and the clinical case. Next. Now I want to present you clinical cases, the patients with a giant tumor, osteoma, exostosis, myeloma, and after it, the defect of the bones. Next. Now we see the classical case of the giant cell tumor of the fibular proximal metaphysis with a pathological fracture. We have a resection of the tibia, fixation with a Ilizarov frame, and osteotomy of the distal part of the tibia. As a gradual correction with the bone transport. Next slide. Now we see the consolidation. Next, please. It's very interesting clinical case with pathological fracture of the humerus with the lytic type of the Gujrat tumor. It's a young man with this X-rays and clinical picture. He came to our clinic. We have the we make the also the resection of all the diaphysis of the humor with free bone correction with the fibula with the bone frame and the frame Ilizarov frame with the intermediate fixation of the wire with the hydroxyapatite and compression of the docking side. Next slide. Now you see the picture in our operation theater. You see also the total defect of the humerus, of the diaphysis of the humerus. You see the tumor tissues in the intermediate channel, and now you see the bone fragment with the bone transport. Next, please. After it, we have a consolidation in this type. Next. But after it, the patient was a fault with the closed fracture of the fibula transport. And we have also, again, a compression monofocal osteosynthesis with the Ilizarov frame and intermediate fixation with the wire with a hydroxyapatite. Next, please. You see the function of the upper extremity after remove the Ilizarov frame. Next, please. X-ray pictures after 2 years after treatment. Next, please. One more case with the post-traumatic pseudoarthrosis with the gonococcal with the right humerus and foreign bodies. Next, please. We have resection also over the total resection of the diaphysis of the humerus and fibular graft osteosynthesis with the Ilizarov frame, compression of the docking side with the intermediary elastic nail with the hydroxyapatite foundation. And after, next slide. And now you see the rejection material of the echinococcus cysts with the non-effective fixation of the plate. Next, please. Now we have a consolidation of the 6 months follow-up. You see this picture. Next, please. Also, the CT pictures of the 4th month follow-up. Next, please. Maybe it's all. I want to hear your questions. Thank you.
Really interesting cases, especially tumor cases, were mind-blowing. Questions from the audience? Yes, Sabari sir.
Yes. Can you see my face now?
Yes, sir.
Yes.
Yes, sir.
Denis.
Oh,
thank you very much. Thank you very much. Spasiba большое. You have shown a lot of cases, and I have the observation and some few questions. One
I
thing,
hear you.
yes, one thing is that your external frame design and at the same time dressing is very good. This is the learning for everyone, that which I learned from Kurgan Center. Dressing from the outside. That is very good. And in the tibia, you have used all the wires, not the pins, only purely Ilizarov technique. In the proximal femur, you have used the pins also. And the middle and lower, only the wires. Okay, that I do. So you have shown one case of Crawford, that is type 4 CPT case, and you treated that one by, you know, that is by normal, not Ilizarov, and you have used the spacer CPT case. And how much time it took? This is number one. And number two questions, in most 3 or 4 cases you have shown you're using hydroxyapatite in case of using the fibula. What is the cost of the hydroxyapatite? This is very good that I have seen in your center in KURGAN. What is the cost of the hydroxyapatite? I don't know. In India, they are using hydroxyapatite with K wire or Ilizarov wire. And what about the cost of that one? This is the case. And last one is the echinococcus that you treated with hydroxyapatite with fibula grafting. What about the outcome? You followed all my questions and observations?
Okay, I will ask it for the first questions. First questions. I think that's it's normally to make a fixation of the spacer about 3 or 4 weeks. We have a experimental experience, and we think that the 3 or 4 weeks is the normal for fixation with the spacer, and after it we remove the spacer and make a bone transfer. At the first question, I agree with me.
You're going the bone transfer, not putting the bone grafting. But musculate technique, they are putting the bone grafting after using the spacer.
Yeah. I told you that we with Professor Bozunov will make that to transpose
that is
from the
new one.
conventional pseudarthrosis by post-traumatic pseudarthrosis, and we also have beautiful results, it seems to me.
Thank you.
The second question you ask, we also have big experience with using of the wire of the intermediary fixation with hydroxyapatites, and we like it because this wire have also conduction and also induction mains, and we love it. We make it. It's not a main fixator. It's just for bone stimulation.
And what about the cost of hydroxyapatite with that wire?
The cost?
Cost?
No, I don't know. Я не знаю. I don't know it.
You don't know?
It's not for me question, Barry. It's not for me question.
But
I
think
just have
a
it.
little bit costly. Okay, thank you.
Thank you, Barry.
Any more questions? Jayant sir, any questions?
There's a question from Praful. How does cement spacer help in CPT?
Repeat one more. I don't understand it.
How does the cement spacer help in pseudarthrosis of congenital pseudarthrosis?
We make a cement spacer about 3 or 4 weeks, and with the post-traumatic pseudarthrosis and with the congenital. And I repeat that we have our experimental experience, and we saw that the 3 or 4 weeks is the more probable for the removal of the spacer with biological membrane, and it will be such good blood supply in this case.
But they don't use cement. After forming the membrane, they're going for bone transportation.
Okay. So
Yeah,
it is
I agree with you.
combination
we-
of masculine with transport.
Yes.
Okay. There's one more question. Most probably it was meant for Amar. Again from Praful. Tips to avoid deviation of the transported fragment.
So I would say the main thing would be stability of frame. If frame is stable, then the transported fragment will have minimal deviation. And if it occurs, one can always adjust with help of hinges and washer. But if frame is stable, then the chances of deviation are very less. And generally, this deviation is addressed at the time of docking.
Okay. Shamsul, you have any comments, questions?
Sir, we don't have any more questions, sir. Any comments from your side, sir, Jain sir?
No, not from my side. The professors already said.
So we can move ahead, sir. Yeah, after your permission.
Yeah. No permission yet.
So we'll now move to the case discussion. First, we'll have the case discussion from Harjeet, sir. He's very famous for his pulley system for the bone transport. Harjeet, sir, over to you, sir.
It's cable system.
Yes.
Cable system, yeah, right, sir.
Hello.
Yes, sir.
Yeah, can I start?
Yes, sir, you can.
Yeah. I'll be speaking on bone transport by cable pulley system. So, bone transport, just 1 minute. Yeah, bone transport is established and time proven method. So when I started around 30 years back, it is still same that you do a corticotomy and fix the bone fragment with wires or pin. And then when ring moves, the bone fragment also moves and the gap gradually regenerate forms in the gap. So, but then there are some problems with this external type of bone transport, that it's very painful and it leaves behind the scars of the pin and wires, linear scars, and sometimes soft tissue bunches up, and at the place of docking, it becomes very difficult to open it. So the alternative is internal transport. So in internal transport, it can be done by just like in this case, bone gap at the proximal metaphyseal-diaphyseal junction. So it can be done by oblique wires. So I did few cases with all oblique wires, but still it's a little problematic because on the end you have to put twisted plates, and then as the bone fragment advances, the slotted rods protrude out and on medially and laterally, and it becomes difficult for the patient because of the bulk of the frame. Then next alternative is cable system. So I saw it first time in 2014. Mr. Baumgart, he showed cases at Asami conference in 2014. So you see there is a this thing which is holding the fragment. There are no wire and pins. So I asked him, how do you fix it? So he told that they have a Teflon anchor made especially for that, and through that they transport the fragment. But that type of Teflon anchor and etc. is not available here. So this is another a photograph from other paper. They are doing a cable and pulley system, but they have not shown how they hold the tracted fragment. So with this principle, I tried, and then I made this cable system of our Indian version. So we use simple, it is very simple. We use tension band wire number 18 and simple pulleys which are available online, and slotted rods, threaded slotted rods. So when doing debridement, at that time you have to decide whether you want to do a cable transport or not, because once you have fixed the frame, then you cannot put the wires inside. So what you do is make 2.5 mm drill holes around about 2 centimeters from the edge of the bone, and take tension band wire about 1 meter. And then from those holes, you insert both ends of the wire from outside in, and then at the opposite end, you again make 2 holes and then pull out the wires. When the wires are out, then the wires can be out through the wound or through the skin. The next is you have to fix the wires to pulley and then slotted rod. It can be fixed in this way or in on a medial and lateral side also. So this is a case where the wires have been inserted, and this shows where is the pulley and this is the threaded rod. So with threaded rod, you just pull. There is no, this is at the time of fixation. Later on, when you start distracting, you remove this pin or wire in the middle fragment. So there is a hold on the bone, on the proximal fragment and distal fragment, and in between there is no hold on the wires from the ring. So precautions are that wires should not be jumbled up, and wire pull direction should be centrifugal to the exit hole in the bone. So this is a case, usual story: fracture tibia, fixation, infection, implant exposed, flap coverage done, still implants are exposed, and infected non-union is there. So in this case, when doing debridement, I pass these wires from this end to the distal fragment. Okay, and then you can distract to those 2 wires attached to the pulley and threaded slotted rods, and then you can have a good regenerate. There is no problem with the regenerate while doing with the cable transport. And another case, again almost same story, but here there is no internal implant, but X-fix is there, and the flap has been done. That shows that the bone was dead. So this much bone was removed, and cable system was done. So in this way, when you distract, there is no almost no chance of deviation of the middle fragment. And this is the result. That's all. It's very simple system. It's very cheap and reproducible. Thanks.
That was quite innovative technique, sir.
So such a wonderful, sir.
Yeah.
Anybody can do it. Anybody, orthopedics, any orthopedic surgeon who is doing bone transport can use these things and do it. Yeah.
Dr. Bari, any comments of yours?
If I have to pass comment, Mr. Singh, you just take it easily. The fundamental principle of Ilizarov methodology. This is not Ilizarov that what you have done. I have seen lots of pins you have put in the tibia. And at the same time, that we know, the fundamental principle of Ilizarov methodology is load and motion. How do you counsel your patient after doing this kind of bone transport? And you are telling that whenever you are putting the wires in tibia, it is very easy, very simple, and very fine. And never, patient, if you follow the basic principle of the Ilizarov methodology in tibia, it is very easy. Patient that does not have any complaint if you follow the principle of the Ilizarov, original principle of Ilizarov. But I don't know. I have seen this kind of cable pulley system, and this is your innovative. And if you, how many cases you have done, I don't know. And do you have any publication of that one, so that somebody can follow your this case? This is my observation. Even then, thank you very much that you have shown your Indian version cable pulley system, and how many cases you have done, and do you have any complications regarding this very big, more than I have seen 7-8 centimeter. So do you have any complications by doing this kind of cable pulley system?
I've done around 15 to 20 cases till now. The problem occurs when the wire which is exiting from the distal fragment in a case of proximal corticotomy, if the direction is not good, then that can break the antecortex of the tibia. So that is the only problem. Otherwise, I didn't face any other problem. Regenerate is no problem. If corticotomy is good, any Ilizarov person doing Ilizarov, regenerate will be there. If corticotomy is not good, then whatever, whether you use external transport, internal transport, regenerate will not form. So basic principles of Ilizarov stability and taking care of corticotomy are there. But whether you do by external transport or internal transport, it's innovation, it's changing. So we have to reach the goal. So I have reached the goal. So whether it is a principle of Ilizarov or not, I don't mind it.
Thank you. Thank you. Thank you.
Yeah.
Amar, your comments.
No, sir, it is excellent method. Only thing is one need to have a good soft tissue sleeve, one thing. And second thing, that these wires should have an adequate strength. At times, these simple SS wire may break. So those cable which are recommended in literature or in Western part, they are using a cable with good tensile strength. This SS wire may give good strength in tibia, but in femur, I feel that it may require more.
Can we use those wires? I mean, cables that are used for circlage.
Yes. Those type of wires are available. I've gone through some articles, and there's a good system from Smith & Nephew which is available for this cable transport, but it is very costly, beyond reach of most of patients.
That is the point. It's very costly, actually.
Yes, sir.
So that's the system I'm telling. That it's a very, it is Indian version and it's very cheap. You have all the segments.
Yes.
Right.
Yes, sir.
That tension band wire 18 number, it's quite strong.
Yes, sir.
It doesn't break.
Sir, any chance of breakage of anterior cortex while doing the transport?
Say the fragment which is being tracted, or
yeah.
Initially I was afraid, but if the holes are around 2 to 2.5 centimeter from the edge, I don't think. And after I showed case where I have put both hands and transported through 2 pulleys. Now I do it that I pass 2 ends and then cut 1 end short and twist it, and then take only 1 wire, just like the system Mr. Baumgart showed. So there is only one wire inside, and then it is coming out. So only there is one hole. Actually, there is only one hole, and the skin is not moving over there. So it becomes almost painless. Patient doesn't feel anything. They are very comfortable. The next which can be attempted is that, say, long transport. So we have to stabilize. So if later on we want to put a internal fixation to reduce the duration of frame, that will be possible because there is no scar in between. So only proximally and distally there are pins holding, and in between it is a virgin area. So we can put a lock plate later on, because now many times when I remove frame in these cases or other cases, when I remove case, I just slide a lock plate and fix it proximally and distally. So it gives additional stability. Even if there is a good regenerate, many times later on some fracture develops after removal of frame. You find so that way I am thinking it may be possible later on.
Praful wants to know, are these wires tensioned?
No, sir.
Please again.
I was wanting to know, Praful was wanting to know, are these wires tensioned?
Tensed.
Tension.
No.
So the question was not whether their wires are tensioned. The question is there increased chances of infection? For we know that wires which are not tensioned, usually for the Ilizarov, they will become loose and they might become infected. So in your case, do you feel that there is increased chances of infection, or what have you encountered in your cases?
When you are fixing wire for bone stability, then you are tensing it, right?
Right.
So those wires, right? This wire is not giving the stability to the frame, but this wire, when we distract it, it becomes tense. So we have to monitor it for distraction 1 mm per day. That we have to monitor. So when we start, say some laxity is there, then you start giving more rate and then monitor. If the distraction is okay, then you go, then you set the rate, whether you are doing 2.25 4 times a day or 0.25 5 times a day for distraction purpose. Otherwise, no. And
so you have not encountered increased chances of infection in that? In none of your cases?
No.
Good. Okay.
Do we have Professor Dennis over here? No. Any experience of using cable at KURGAN? Dennis sir, do you have any experience of using cable system or similar things at KURGAN? Please unmute, sir.
Okay, I agree with the colleagues, but we have not big experience of this side, and we also have classical methods of the bone transport. Are you hear me?
Right, sir. Any more comments, or like Professor Omar, any comments? No. Okay, sir. So, Jayan sir, shall we move to the next talk? The last. So we have a case discussion by our dynamic Dr. PURAV KANSARA. PURAV, please share.
Okay. Hello, everyone. I'll have to go outside and start from beginning. So I'll stop here.
Yes, first go to the first slide, then share.
Okay. Why am I not exiting?
You don't have to exit. You can just minimize this and go to the PowerPoint.
Okay, okay, yeah.
So go to the first slide and come back to Zoom.
Yeah, yeah. Share screen.
And also share.
Share. Okay. I hope I am audible clearly.
Yeah, please go ahead.
Yeah. So I'm going to talk about bone transport of femur with Ilizarov or rail fixator. Not going ahead. Why is that?
Please click with the mouse with a touchpad, or please click on that.
Yeah, yeah. Okay.
Yeah, perfect.
Yeah, okay. So I will start with the case. It was a 60-year-old lady. She had chronic osteomyelitis of femur, no medical comorbidities, and immunocompetent person. There was a discharging sinus from the posterolateral aspect of thigh. Knee range of motion was normal. And we can see the x-rays. The involved bone is clearly visible. I went ahead with radical excision of the bone. So I removed 5.5 centimeters of the bone. Actually, I put on the Ilizarov fixator first, and then I excised 5.5 centimeters of bone, which was the involved bone, and did a osteotomy in lower femur. The culture microbiology result showed E. coli growth, and tablet levofloxacin was sensitive, so it was given for 1.5 months. So this is a distal to proximal bone transport of femur. And gap was almost obliterated at after 2 months. And docking and bone grafting was done at 2 months. Bone graft was autogenous corticocancellous graft. I was trying to show with markers. Yes. So in this frame, we have to notice that all the rods have to be parallel to anatomic axis of femur in both views. And that way, bone transport fragment will not deviate. Example of another patient to show that parallelism of rods is very important. And in the clinical picture also, we can see that the rods are parallel to each other and also to anatomic axis of femur. So in this patient, there is distraction occurring between the arch and the first ring. And in my operated patient, there was compression occurring. So basically, if we want compression or distraction to occur, then the rods have to be parallel to each other and also to anatomic axis of femur. This is X-ray 3 months after docking. There is healing of bone, and X-ray 6 months after docking. Fixator was removed after 10 months of docking surgery after progressive dynamization. And this is the function at 1 year and 2 months. She is free from infection, normal alignment, normal leg length, but the knee is stiff. Now, was it possible to do the same case with LRS fixator? So I think it was possible. We can put 3 clamps total as shown in this diagram, and we can do a distal femoral osteotomy as shown by a red line. Now, the important thing is that the minimum size of a fragment for a LRS clamp has to be 5 centimeter. Then only pinhole number 1 and 5 can be used. If it's a smaller fragment, then I think Ilizarov fixator is better. And if you want to do osteotomy and distraction, then the minimum size of fragment required is 15 centimeters. So 5 centimeters for each clamp, and in between 4 to 5 centimeters. Another case of bone transport with LRS. he was a 24-year-old male and osteomyelitis of femur, infected non-union. So the bone shown in red circle was necrotic. It was removed and bone transport was done with LRS fixator. Now this is accelerated bone transport. So some acute shortening has also been done and upper femur osteotomy has been done for bone transport. Progress of bone transport. The fragment reached at 2 months and at 2.5 months, acute docking and bone grafting was done. LLD eliminated after 3 months of distraction. So even after this acute docking, there is some shortening. So the lengthening continues at the upper femur osteotomy site. And the bone transport frame here is now converted into a limb lengthening frame. X-ray taken at 8 months after bone grafting. And this is the final X-ray. Now, does it mean that LRS is better than Ilizarov for all cases of femur bone transport? So we should know that correction of any deformity is possible with Ilizarov fixator, but not with a rail fixator. So LRS has its limitations. And the deformities which LRS can correct are only translation in the plane of pin insertion and angulation in the plane of pin insertion. It cannot correct any other deformity without placement of new pins. So LRS is a very non-forgiving implant. This slide shows use of LRS for correction of a translation deformity. We just have to pull the pins towards ourselves for reduction or push. And this slide shows correction of angulation in the plane of pin insertion. So this is a varus deformity and the pin placement is pure horizontal, pure lateral to medial. For that reason, we can correct with LRS micrometric swivel clamp. If insertion was in some other plane, then this would not have been possible. Then the only way possible is to put new set of pins. So here with the micrometric swivel clamp, varus deformity has been corrected, which is shown in the last X-ray. But if we have a deformity with a Ilizarov frame, we can correct with hinges. Now in this was a case of bone transport and there is varus deformation of the region rate and also some translation. The cora is at lower end of the region rate. So I planned to do to put hinge on the concave side of the deformity and reduce this deformity. So the yellow arrow is showing hinges on the medial side of the bone and I put a rod on lateral side to shorten it and it corrected the deformity. Now with a Ilizarov frame, I can correct deformity in almost any plane. I can even do rotation correction. All this is not possible with a LRS. So I come to the take-home message slide that segment excision and radical debridement can only be performed if one knows how he can reconstruct the bone loss. Advantage of Ilizarov fixator over LRS is that it is forgiving and changes in alignment after surgery is easier as compared with LRS. Ilizarov bone transport of femur is more challenging than tibia, so one must have enough experience in simpler cases before undertaking femur bone transport. It is a good idea to perform some cases of Ilizarov bone transport and then use LRS fixator for femur. Patient and family must be mentally prepared before starting lengthy journey of bone transport. Thank you.
Nice cases, PURAV.
Thank you, sir.
Any questions, comments from the audience?
I have two questions. Can you hear me?
Yeah, sir.
Yes, sir.
Thank you, Dr. PURAV, KANSARA. before doing the surgery, when you are removing the fragment, do you go for fistulogram or sinogram routinely? This is number one question. Number two questions, in the femur, you have shown very good cases. And do you suggest the patient for a special cot, how they sleep in the bed?
Yes, sir. I'll answer the first question first. I don't routinely go for a sinogram or a fistulogram. I just open the sinus with knife, and wherever my blunt instrument is leading to, I go to that point and I take the judgment regarding bone involvement by naked eye examination only, the vascularity of bone. And sir, the sleeping position with Ilizarov, I mean, it's really, I mean, I can't think of any solution. There is no easy way out. I mean, if you can guide or anyone else can guide, it will be great, sir.
There is a special cot for femur.
Yes, sir. What we can do is just have a slot removed from that mattress so that patient will not have a flexion deformity while patient sleeps.
That's special cot for femur. And there is a space you must make it. Yeah, you can do it very easily and comfortable for the patient. Otherwise, patient, if a straight way lies in the bed with femur frame, it is difficult for the patient to get comfortable situation in the bed. Thank you.
Yeah, Arjit sir.
Yeah, the problem with femur sleeping posture occurs because we use full rings. If you had noticed in my tibial frame, I'm using only 5/8 rings. And those rings are not the 5/8 rings which are being given by the company as a half ring. So I got made a thicker means broader 5/8 rings. So I use now in almost all tibia and femur cases 5/8 rings. So backside is free in the tibia also and in femur also. And if you use full rings in knee, in femur, then chances of flexion deformity of knee are also there, in addition to problem of the sleeping, unless the patient keeps the leg elevated all the time. So I have been using 5/8 rings, which are not as broad as the half rings for you, which we make a full ring, but they are broader. So the strength is good, and the posterior half is totally free.
We can even stack 2 5/8 ring on each other to strengthen, or we can put very small rods to make a block.
If you use normal 5/8 ring or half ring and combine it, then when you are putting wire fixation bolt, you will have difficulty.
Yeah.
Because then the broader part, and then you may not sometimes pass the ring, or there may be problem. So I got made 5/8 rings which are broader than that. That same you can also do. I can show you those rings later on.
5/8 rings we have been using the joint areas also, proximal tibia or distal femur. Rest place we use either rings or in the proximal we use arches.
No, I use those especially made 5/8 ring in total frame.
That is custom made, sir. Right, I got it.
Yeah, yes. They are broader. Say if the normal is 1 centimeter, it is 1.5 centimeter.
Okay, sir.
If you go to the history of Ilizarov, then there was one person whose name was O. Ganeshan.
Okay, sir.
O. Ganeshan used to use 5/8 ring only, and his rings were special of alloy, and he had holes in the ring like that, through which wire used to pass.
regarding this, Oganessian, Professor Oganessian was my teacher also in CITO, Central Institute of Traumatology and Orthopaedics. In 2003, I met him and he died in 2009. Listen, Oganessian and Ilizarov was the rival. Always rival. Oganessian, Professor Oganessian, he has used all the time half rings everywhere. And that is not used in Russia also. That is the main thing. And cost of the Oganessian apparatus is much more costlier than Ilizarov apparatus. So they are using in only in CITO, Central Traumatology and Orthopaedics, not too much. In Ilizarov Center, no Oganessian apparatus nowadays. Thank you very much.
I attended his first conference around 35 years back at Ludhiana Christian Medical College. There I saw him using these rings. Then I got one set, but then later on it was not available anywhere.
Yeah. Thank you.
Yes.
Singh sir, can we use the cable method for femur also?
Oh, yes, we can. I have used in one or two cases. Femur transport cases are not that much in frequency as tibia. So it can be used. And that I told you that Mr. Baumgart, he showed in femur also that cable transport. So it can be used. There is no problem.
Purav, there's one question for you.
Yes, please.
When you're lengthening, having a deformity in the tract of regenerate, does the use of hinge for correction of deformity affect the regenerate?
So in the X-ray which I showed, I did closing wedge. So the regenerate underwent loss of tension. It was not stretched acutely. If it was stretched acutely, it can be injured. But it was a closing wedge. So I put hinge on the medial side of a concave deformity. So the lateral side was relaxed, lateral side of the regenerate, and the medial side was having same tension. But I cannot put it on the lateral side, which means the convex side.
Jan sir, we have some question from the internet, YouTube. Can I ask?
Yeah.
This question from Nizo Beats, country is not mentioned. For someone who did cosmetic limb lengthening and has an internal nail in it, runs into a non-union. How do we treat that? and we have more questions. Is the iliac crest graft enough to fill the gap? If not, these are not eligible questions.
Yeah.
This is a question: how do we avoid nerve irritation during lengthening?
Limb lengthening to last month ho gaya, I think so. These questions,
These questions are already asked. Replied, sir.
But still, at 1 mm, I hardly faced any problem of nerve irritation in cosmetic lengthening.
Yes, sir. Yeah, we can simply do a perineal release if there is a nerve palsy and large lengthening on the nail.
Large lengthening and pterygium and these type of conditions, there you have to do this release of peroneal nerve.
Yes,
and all.
exactly.
And non-union also is not very common. With nail in situ, again you can treat it just like by doing dynamization and PRP and bone graft. What all? Amar, what you all want to say?
Means I have not encountered any cosmetic lengthening case. Means I have not treated, sir.
Okay.
So these questions are, I think, already been discussed, sir.
Yes, sir.
Yeah.
And probably those are from laymen, not from orthopedic surgeon.
Yeah, exactly.
So one question for all the panelists regarding distraction between an arch and a full ring. So I mean, I only showed that case, but I think it has a limited capacity of lengthening. The varus will occur very fast. So I try to distract between two full rings whenever possible. Like if I have to put a full ring just below scrotum, then I will put. So what is the opinion of other speakers on that?
I'll use a half ring and then connect it with the help of an Italian arch oblique support to get the maximum width medially. I mean, going maximum medially by help of a oblique support.
Oblique support.
Means it should cross the medial border of femur.
Yeah.
Your dissection
is-
and probably all 4 dissection rods should be equidistant. Means 2 anteromedial, posteromedial, anterolateral, posterolateral. You should have 4 such dissection rod. And those medial rods should be medial than the medial border of femur.
Can you cover large gaps with this technique? Can you do large bone transports?
Means I've done even up to 15 centimeter.
My maximum is 6 centimeters and 115 wala is under treatment. I can't comment at this moment.
I've done till
But-
19 centimeter maximum. Yes, sir.
But yeah, instead of a full
Yes,
ring
sir,
at the
sir.
level of scrotum, patient not able to walk, I'll go for a oblique support and shift it that medially.
Means
But then the pulley method, I think it is more appealing in that way because the direction of traction is straight in line with femur. So, I mean, I think I would like to try it.
Still, if you are using pulley, then also varus will occur because if you are using Italian arch proximally and full ring in the middle, generally you are putting 3 or 4 rods. Maybe you put 1 oblique support and come medial to the line of the shaft femur. So it's very common problem. So now what I do is between Italian arch and the ring, I put almost 5 or 7 or more rods. So the lateral side remains straight. What happens is there is a 2 or 3 rods, the rods bend. Because of the pull medially, the rods bend. So you have to keep the Italian arch and the ring parallel. So you, on the lateral side, instead of putting 2 or 3 rods only, which we generally put in tibia or other fair, you put here 5, 7, 8, whatever rods you can put and then fix. So the lateral border will be very strong. So the cantilever effect will go off because the lateral side is very much strong. That may help.
In very large gaps, especially in femur, in order to avoid translation or angulation, I've been using transport over tens so that it works as a guide wire and we can remove it later. Dr. Amar, what is your take on that?
Yes, sir. Yes, sir. It is a very good option.
Yeah. And I do wire only frame.
You are using 10 okay, for transport.
Yeah. Transport over 10.
So it doesn't increase the incidence of infection. So 1 wire of pulley, if you are using cable pulley, then 1 wire will not increase the chance of infection, as someone was noticing and asking. Okay.
Yeah, right.
Okay. So Shamsul, last comments, final comments from Professor Denis, and then we conclude.
Yeah. Professor Denis, we request last final comments from your side for this webinar, sir.
Okay, I want to add that with varus deformity between the lancering, I think that's more possible for correction is to put the proximal base of the frame with the varus correction and to use the hinges, not rods, only the hinges with the varus correction. And that's why you have possible to correct the varus deformity between the lancering, okay? With when you have proximal base with the varus correction. It's my mind. We often used it in our clinics when we have a lancering all the 5 or 6 centimeters of the femur, example.
Thank you, sir.
Okay.
Sir, shall we conclude? Is there any more comments? No.
Any questions, any comments? Or Amar, you want to add something?
Nothing,
Or-
sir. Nothing, sir.
Okay.
I have one question for Amar, sir.
Yes, please.
Yeah. Full.
So, like, yeah, so like if you are using, like you said, when you are using an Italian arch, and you have that anteromedial and posteromedial connections, they
Means
should cross the medial border of the femur.
Yes, that
Now,
will.
there is no problem with the anteromedial. Usually, there is this problem with the posteromedial connection.
Yes.
So that will touch the bed.
Mhm.
So you have any tips like what you should do?
No, that's why I said that we should cut the mattress, that part of mattress, length of mattress in which the frame is there. So when patient lies down, then he will be in a flat position, and the ring will be touching the cot.
It will be going into that hole, into
Yes,
that.
yes,
Okay, so you always use that mattress
Yes.
for when you are doing femur cases.
Yes, we need to teach them, and they should use that at their home also.
Okay, okay, okay. So I have had that problem.
That should be at least 4 inch thick.
Okay, okay, fine. Yes.
Thank you, sir.
Thank you.
Okay. Shamsul, your concluding statement, and then we leave.
Yeah, thank you, sir. So, thank you, everybody. Thanks, Professor Denis, Dr. Amar, sir, Jayant, sir, Ajit, sir, Bari, sir, Amar, sir. Thanks for a wonderful interactive session. I hope all the young surgeons have learned a lot from this, and we'll be doing this more. And next month, most probably, we have a webinar on compound fracture. So we will invite everybody in that. And besides, we'll invite all the state representatives to do their budding Ilizarov webinars, and give chance to young surgeons, so that we get more of learning of the basics. With this, I just thanks everybody, and good night to everybody. Thanks. Thank you a lot, sir.
Thank you.
Okay. Good night. Thank you. Thanks.
Thank you.
Good
Thank you,
night.
everyone.
Good night. Thank you very much.
Good night.
Good night.
So can we stop live?
Yes.
Thank you, sir. Nice. Please end the Maharshi. Please end. Maharshi, are you there? Okay, I'll do.
No, yes.
I'll do. I'll have to take over the command.